So it's 3, 2, 1. So we are live now.
Hi, good evening, everyone. It's an absolute pleasure to be the moderator for this very important topic on bronchiectasis. And we have a wonderful faculty here today, and I'm really looking forward to learning so much from them. First of all, before I go any further, I want to thank the Indian Chest Society in general, the office bearers, Dr. Sandeep Salvi, Dr. Raja Dhar, and of course, the person who's put this whole program together, Dr. Amita Nene, for giving me this opportunity to interact with all our wonderful faculty. We will be starting with the radiology. Dr. Khushboo Pilania will be taking us through that. And then Dr. Raja Dhar, we all call him the Raja of Indian pulmonology, will be taking us through the management of bronchiectasis. And there's no better person to do this. I'll come back to introducing him later, but we know that he has been key in the Embark India project, which I was very privileged to join. So when we talk about bronchiectasis, it's something we realize is not as rare as it used to be thought. The pattern of bronchiectasis is what we're going to discuss, the etiologies and how to manage it. But basically, it is a condition where you have an abnormal and a permanent dilatation of the bronchi, initially thought to be irreversible, and still probably the true definition of bronchiectasis is irreversible. But we learned during COVID that what we thought was a traction dilatation of the bronchi seemed to settle over time, making us rethink our definitions of what is bronchiectasis, what is traction dilatation, and we'll be answering some of those questions. So without further ado, I'm going to ask our panel to come in at the end, but we'll be starting with the talk from Dr. Khushboo Pilania. A very brief introduction of Dr. Khushboo. And of course, before I forget, I must thank our tech team for today. And very importantly, Lupin, who are absolutely wonderful in terms of support right from the beginning through all the talks that we've had. So a very special thanks to ICS and Lupin. I'll be inviting Dr. Khushboo first. Dr. Khushboo Pilania needs no introduction, really. The pulmonology groups around the country have heard and seen her. I last saw her less than a month ago when she did this absolutely wonderful radiology quiz. Her special interests are in chest radiology and musculoskeletal radiology, as well as MRI. She is the founder and consultant radiologist at Eisen Imaging and Interventions in Noida. And she's a consultant radiologist with Dr. Bhavin Jankari at Picture This, a member of multiple associations, professional associations, and has a lot of publications, national and international, conference presentations, national and internationals, book chapters. And we're always very grateful to hear her at pulmonology meets and conferences. So over to you, Dr. Khushboo. Looking forward to your talk.
Thank you so much, sir. That was a super kind introduction. I'm not sure how much of it I deserve. It's always a great pleasure for me to be a part of these meetings. I learn more than I'm able to, put ahead. So the topic that I will be doing today is HRCT in bronchiectasis. Just wanted to check if my screen is visible.
Ma'am, not yet.
Okay. Just putting off my video. Is it visible now?
Yes, ma'am, it is visible. You can make it full screen now.
All right. So I think it's visible now. So what I will be doing today is talking about HRCT in bronchiectasis. The topic that we are discussing today is obviously bronchiectasis, and as we go about it, the first part of it is to diagnose bronchiectasis clinically suspect bronchiectasis. Often when we are in a dilemma, we get a CT scan done to confirm if it's bronchiectasis or not and figure out if we can give some idea to the underlying etiology. So the various clinical issues when we talk about bronchiectasis is obviously the diagnosis, the question whether there is bronchiectasis or whether there is no bronchiectasis. After we've been able to diagnose that and confidently say that yes, there is bronchiectasis, the next question that comes to us as radiologists and to you as a referring physician or a pulmonologist is what is the underlying cause, if it's not an obvious cause. And then we also talk about whether there is concomitant airways or smaller airways involvement or not. I will not be talking about small airways as much today. So we'll stick to the larger airways and how to diagnose bronchiectasis. So when you talk about diagnosing bronchiectasis, we need to understand the anatomy of the bronchiectasis first. That bronchus is always a part of the bronchovascular bundle. So a bronchus and a vessel, they always move side by side and they are referred to as a bronchovascular bundle. So when you look at this, this is a bronchus, this is an artery. They always move side by side. So this is an artery and there's obviously a bronchus adjacent to it. This is an artery and there's a bronchus. So normally the broncho-arterial ratio is less than 1, which means that this diameter of this bronchus compared to the diameter of this artery is always lesser. When this ratio becomes more, that means the bronchus is abnormally dilated. And the definition of bronchiectasis is, as Dr. Mulli already said, it is abnormal dilation of the bronchus. So when it is more than 1, it becomes an abnormal broncho-arterial ratio. So then the next criteria is that in a normal HRCT, there is no bronchus visible in the last 2 centimeters. So that means that if we look at this periphery of the lung, we should not be able to see any bronchus. So we are seeing some bronchus here, we are seeing some bronchus here, we are seeing a bronchus here. But in the last 2 centimeters, you should not be seeing any bronchus. So if you see a bronchus in this last 2 centimeters, that means again, it is abnormal and it is bronchiectasis. Then the normal bronchus taper. So the bronchus are dilated and as we move towards the periphery, they start decreasing in size. If they remain of a consistent diameter throughout, that means again they are abnormal. So what are the signs of bronchiectasis? As we discussed that the bronchus larger than the artery. So you have a bronchus and an artery moving together as a bronchovascular bundle. This is the bronchus, this is the artery. The diameter of this bronchus is larger than the artery. There is wall thickening. So how do you appreciate wall thickening? So there is no specific criteria or measurement for wall thickening. It is more of a visual eyeballing. Over time, when you see more and more of CT scans, you will realize that such a prominent wall is never seen in a normal bronchus. So if I go back to the previous slide and try to show you how the wall of a normal bronchus looks like, you can see this. They have a rather imperceptible wall. The wall is not like very distinctly visible as it is seen in this case. So you see very visible and a thick wall. So bronchus larger than artery, and when there is wall thickening, we know it is bronchiectasis. Apart from that, if you see such straight prominent bronchus which do not taper. So again, a prominent straight bronchus, which we also call the tram track sign, and these bronchus move towards the periphery without any tapering. And then visibility of the peripheral airways. That is, if you draw a circle marking the peripheral 2 centimeters of the lung and you see any bronchus in this peripheral 2 centimeters, you know it is bronchiectasis. So this is an abnormal bronchus. You should, although, you know, this may be of a normal size, but the visibility of a bronchus in the peripheral 2 centimeters means it is abnormal because towards the periphery, the bronchus should have tapered. Now, this is how you diagnose bronchiectasis. So if either of these criteria are there, that is bronchus larger than the artery, wall thickening, lack of tapering, and visibility in the peripheral 2 centimeters. So if any of these four criteria are present, it becomes bronchiectasis. Now there are various different types of bronchiectasis. So then we define them basis the morphology. So the dilated bronchi can be like tubes when we call them tubular. They can be like sacs dilated tapering on either ends when we call them saccular, or they can be like cysts. So they can be dilated, rounded, cystic. Often the variety of, the nature of bronchiectasis helps us define the underlying etiology. So for example, the tubular variety is more common with ABPA. Then the saccular can be seen with any variety. Cystic are more common with tuberculosis, but then there are no such rules. So all the various etiologies of bronchiectasis can all cause varying different types of bronchiectasis. Then when there is bronchiectasis, they can often be mucoid impaction. So these dilated bronchi can be filled with fluid. The fluid can be simple mucoid or it can be high attenuating mucoid. So these are various signs which help us define the underlying etiology. So this is where the second question comes into light when we talk about what is the underlying etiology. There is a long list of underlying etiology. So they can be developmental when it is a genetic case, in which case we think of diagnosis like cystic fibrosis, Cartagener's syndrome, Meniere's disease, then infections like tuberculosis, bacterial, viral, and then entities like allergic bronchopulmonary aspergillosis and rheumatoid arthritis. So this was a beautiful, beautiful paper by Dr. Rajadhar sir and his team, wherein they showed how bronchiectasis affects Indian population. And we see that tuberculosis tops the list, wherein it accounts for 35.5% of bronchiectasis in India. So when you see bronchiectasis, this should be topmost in your differential, that it could be due to some underlying tuberculosis, some past tuberculosis, especially when it is focal, asymmetric, then this should always be top on the list. However, certain cases wherein you see such a symmetrical, predominantly central tubular bronchiectasis, then in such cases, there are few entities that we should always keep in our mind. Like, so for again, you see these tubular bronchiectasis, predominantly central. And when you go to the CT scan, you see this high attenuation mucus sign. So these are dilated bronchi, and this is a plain CT scan. You see no contrast in the heart, no contrast in the aorta, but you see some bright tubular structures which are labeled as high attenuation mucus sign. So this high attenuation mucus sign is very typical of allergic bronchopulmonary aspergillosis. So when you see this, you should keep a high index of suspicion for the same. So let's look at this case wherein it's a 33-year-old with cough and expectoration. December 2002 scan, you see this conglomerate of tubular bronchiectasis with high attenuation mucus sign. You move to September 2003, this area develops into a consolidation, and you see areas of tubular, more exhaustive tubular bronchiectasis towards the bases with peribronchial thickening. You move to 2007, you see that the consolidation shifts to a different place with still a high attenuation mucus sign at two sides and tubular bronchiectasis. And then again a consolidation with high attenuation mucus sign in 2008. 2008 scans also showing good areas of bronchiectasis and some consolidation. And then the 2012 scan shows only bronchiectasis, tubular central bronchiectasis, peribronchial thickening, some scattered clusters of centrilobular nodules. So this is something which shows a fate of bronchiectasis or how the bronchiectasis develops. This was a case of allergic bronchopulmonary aspergillosis because this is how they show a waxing waning course with areas of mucoid impaction, clearing, redeveloping, getting infected. And over time, it leads a lung with tubular bronchiectasis. So this is something which shows how bronchiectasis finally develops. So over time, due to these repetitive insults, these dilated bronchi become irreversible, as is said is the definition. And these irreversible dilated bronchi are sites which harbor recurrent infection going ahead. And again, an infection in 2012. So now another case, which was a 60-year-old man with long-standing asthma and recurrent infection. You see these tubular conglomerates of bronchiectasis in both lungs. So these are these dilated tubular bronchiectasis in both lungs, some scattered areas of centrilobular nodules. So as I mentioned earlier, often these small airways are associated with larger airways. These are all patchy areas of bronchiolitis. These larger areas are bronchiectasis with peribronchial thickening. But do we see something else in this case? So Obviously, the question here is, what is the underlying etiology, is what we were talking about. The first case that I showed was allergic bronchopulmonary aspergillosis. We saw the high attenuation mucus sign. In this case, again, I'm seeing a diffuse, it's not a focal single-site bronchiectasis. I'm seeing diffuse bronchiectasis. But I also see a dilated trachea with these diverticuli. So again, you look at these main stem bronchus, they are all dilated, irregular with diverticuli. What does this show? So when you see such an appearance, you should be thinking of Meunier-Kuhn's disease. You do this MIN-IP and you see these, trabeculations within the bronchi so well, these bronchial diverticula so well. And this is a Meunier-Kuhn's disease. So this is an entity you should keep in your mind when you see a diffuse involvement with bronchiectasis. Tuberculosis becomes a bit less likely, though we cannot rule that out, but then we should keep these certain entities like allergic bronchopulmonary aspergillosis, Meunier-Kuhn's disease in our mind. Look at the trachea, look for high attenuation mucus sign, which helps us point the diagnosis. So what are the diagnostic criteria for Meunier-Kuhn's? It is tracheobronchomegaly, affects males in 3rd and 4th decades. The tracheal diameter more than 3 centimeter, right main bronchus more than 2 centimeter, left main bronchus more than 1.8 centimeters. There can be diffuse dilation. There can be a diverticular disease, or there can be a diverticular disease with distal saccule. So we saw this case with dilation and diverticular disease. So again, we look at this case where this was a 32-year-old with mucoid expectoration and repeated infections. Again, we are seeing a cluster of dilated bronchi. It is more profuse in right, but there is significant bronchiectasis on the left as well. You see this bronchovascular bundle. You see that the bronchus is much larger than the accompanying artery. You see diffuse bronchiectasis involving both lungs. This is a 32-year-old male. And again, we saw that the tracheal diameter was quite high. It was around 2.7 centimeters. So we should be thinking of Meunier-Kuhn's disease in this case. Now, this is a 15-year-old, again with mucoid expectoration, bilateral lungs involved, symmetrical bronchiectasis, not a focal single-site bronchiectasis, some distal clusters of centrilobular nodules. Again, you see diffuse bronchiectasis, predominantly central, tubular, peribronchial thickening, and bronchiolitis. When you look at the CT scan of the abdomen, you see that the pancreas is infiltrated by fat. Young boy, 15 years old, with diffuse bronchiectasis, no past history of tuberculosis. We should be thinking of cystic fibrosis. So that is the another entity. So these were the issues that we were dealing with. How to diagnose bronchiectasis? You look at the broncho-arterial ratio. You look at the fact that the bronchus tapers towards the periphery. If it does not taper, it is bronchiectasis. If you are able to see bronchus in the peripheral 2 centimeters, again, think of bronchiectasis. If the bronchial wall is significantly thickened, think of bronchiectasis. This is how you diagnose bronchiectasis. Then look for certain signs, especially in cases where there's diffuse both lobes involvement with bronchiectasis. Single lobe, single site involvement, most likely a sequel of some prior insult, of which tuberculosis stops. But when there is diffuse involvement, think of entities like allergic bronchopulmonary aspergillosis in an asthmatic, where you see high attenuation mucus as well. Think of Meunier-Kuhn's, think of cystic fibrosis, think of Carter-Jenner syndrome. So these entities should be thought of. So that's what is from my end. Thank you. So in case there are any questions, I'll be happy to take.
Thank you, Dr. Khushboo. Do we have any questions from either the panelists or the audience? I have one question while the others are thinking, Dr. Khushboo. Does the terminology varicose, cystic, and tubular make any difference in our overall impression of how the patient is going to do? Does it matter to the prognosis?
So that is something I would rather ask you, because as a radiologist, the way it matters to us is that we try to diagnose the underlying etiology basis the variety or the pattern of bronchiectasis that we are seeing. So we see that the cystic bronchiectasis is more often seen as a sequel of some prior insult. The tubular bronchiectasis is seen more often with allergic bronchopulmonary aspergillosis. But how does it prognosticate the patient? that will be something that I would also like to take an insight from you into.
I mean, I don't really know, but what I've read is that cystic bronchiectasis has the worst prognosis of all, tends to be the most severe, at least.
Okay.
I don't know about the others. Raja, any idea? Because I've always wondered why we, bother to describe them with these terms.
I wonder.
Yeah. So I think there are two aspects, Murli. One is what you talked about, the fact that the prognosis to an extent is related to the anatomical variant of bronchiectasis that we're speaking about. The other, I think, is what sort of chest physiotherapy you use in these people is actually relevant to what form of anatomical bronchiectasis you have. For instance, saccular would be far more responsive to postural drainage as compared to what a cystic is. And a cystic, for instance, produces very little sputum, which is why our post-TB bronchiectasis, which is mainly cystic, is dry bronchiectasis. You don't get a lot of sputum up in patients with post-TB. So I think that's another correlation. I also had a question for Khushboo, if I'm allowed to. So Khushboo,
Certainly.
Yes.
Great talk. So
thank you, sir.
We have some patients who have a phenotype, what we call a phenotype of bronchiectasis, but they radiologically don't have bronchiectasis. So we have these patients who produce a lot of sputum, phlegm, they keep getting exacerbation, the sputum is yellow, turns purulent during exacerbations. However, they don't match the radiological definition that you spoke about beautifully in your talk. So do you look at airway wall thickening? Do you think these are sort of people who potentially would become bronchiectatics in the long term and hence should have follow-up CT scans to look at airway wall thickening, look at airway dilatation? Or how would you define them radiologically?
So, yes, sir, this is something that we've also been seeing and we've been struggling because often the patients come to us and we are told that this patient is producing phlegm and mucus. And then we say that, no, we are seeing nothing on the CT. It's absolutely normal. And nobody's, taking us for that. But yes, this is something that I have seen over whatever experience I have, that the bronchial wall thickening is there in these patients. So, but then that is something very subjective. So we still do not have an objective criteria that I can tell you that this much is the bronchial wall thickening, at which point we label it as a thickened bronchial wall. But when we go back and correlate, we always realize that these patients who are mucus producing and they're producing a lot of phlegm, they often have some reactive thickening of the bronchial wall, which will eventually possibly go into an irreversible dilation and then they will thicken up even more. So maybe we need to develop some more subjective criteria or develop more experience to reading the CT scans by seeing more normal ones.
Sure.
And perhaps when artificial intelligence gets into the act, they'll be able to measure it.
They are into way, but there are big challenges, sir, into it, because, to be able to match the quality of the scan to get a persistently same level of scan is like very tough. So then they face that kind of a challenge. I think it's more of an MDD which will be able to, pick this up. So if you tell me persistently it is there, then obviously by fifth scan, I will be able to tell you before you tell me that it's there.
And of course, another group are the ABPAs who have not yet developed bronchiectasis, but are, sensitized. They tend to produce a lot of this slightly abnormal sputum. So I don't know if that's another group we should be following up, to answer this question. Bronchitis phenotype moving into a bronchiectasis phenotype. So, do any of the other panelists have any questions? I haven't. Wait a second. There is a question coming in from Dr. Tridib Chatterjee, who's always, very articulate about these things. And from Dr. Sachin Raghuvanshi. Dr. Sachin asks, where do you measure the tracheal dimension for Monia cone?
So just immediately above the tracheal bifurcation is a good site, but it is predominantly a diffuse dilation. So it's not a focal dilation. It will be a generalized diffuse dilation. So ideally, you can measure it anywhere along the length of the trachea. It does not make a huge difference.
Would you measure it in what is the widest visually?
Yes. But sir, most of the times there will be a diffuse and a generalized dilation. So, I mean, if I see just one side, say it's saying 3 and rest all are like, 2.8, 2.7. So that's how it will be.
Dr. Tridib asks, for ham, do you use Hounsfield units or check it against the skeletal muscle density?
Check it against skeletal muscle density or the adjacent one, because that's
typically the paraspinal or paravertebral muscle.
Yes.
Which is in the same cut. Yeah.
Yes.
Dr. Milan Modi asks, how many ABPA fulfill all the criteria? I don't think we should trouble Dr. Khushboo with that. I'm sure Raja will be covering it in his talk. If he doesn't, we can take it up in the question answer session later. Dr. Saikat Bhaumik asks, please share some pointers regarding how to differentiate between tubular, saccular, and cystic varieties.
So one of the best ways to do it is get your images in soft copy, do min IP. So when you reformat coronals and do a min IP, you will be able to differentiate. Then you'll not even ask me, because the tubular will be like tube, cystic will be like cyst, but we'll be able to see it only on the min IP, because you don't see them, see the good communication or lack of communication on the single scan image that you get on your films. So then they will be like tubes and cystic will be like cyst. And on the min IP, you'll be able to appreciate it. Try doing that. If there is an issue still, let me know. I will.
Yeah, I think that's very clear, your explanation. Again, telling us that every time we need to rush into, we need to insist on getting the DICOM images as far as possible. So,
but it's always possible.
Yeah. I think some of the smaller places,
So nowadays, sir, the way teleradiology has taken up, the smallest of the small places is getting it reported, from across the oceans.
Yeah,
so
I
if
agree
anyone
with you
tells you, don't believe them.
Push them to get it, isn't it?
Exactly, sir. Just push them.
Is there a specific type of bronchiectasis, Dr. Hamidas, usually associated with post-endobronchial obstruction, for example, endobronchial tumors?
Most of the times, these are tubular bronchiectasis.
Okay. Many of the other questions, I think, are not related to etiology and will be answered by Dr. Raja. So in the interest of time, Dr. Khushboo, thank you. As usual, you're brilliant and you keep things so clear and simple. Looking forward to hearing you again. I'm going to move on to introduce Dr. Raja Dhar. Raja really needs no introduction. I mean, everybody knows Raja. We've heard him. We've been dazzled by his talks. And he's a very dear friend. But, formality demands I should introduce him. So he's the director and the head of the Department of Pulmonology at CK Hospitals, Kolkata. He is the director of research and education at the National Allergy, Asthma, Bronchitis Institute in Kolkata, along with his former professor, Dr. Ghoshal. And they also bring us a lot of these very educative talks. He is the director of Hermes Exams for Asia, the European Diploma of Respiratory Medicine. He's the director of the Asia Pacific Alliance for Control of Influenza Apache, the joint secretary of the Indian Academy of Allergy, and so on. He wears many, many hats, including the founder member of the Southeast Asian Academy of Sleep Medicine, which, Raja, I'd like to join also. 157 international and national publications in index journals and abstracts, along with 23 book chapters. He is the lead investigator and author for Embark India. And thank you for inviting me to join you all. He's the associate editor for Respirology, the associate editor for Pneumonia, and he's on the editorial board for numerous journals. He's won the Dronacharya Award for Excellence in Continuing Medical Education, one of the most deserving people to get it, the Indira Gandhi Gold Medal for Outstanding Achievement in Medicine, and has coordinated the DNB courses for the last 8 years, starting the first DNB respiratory course in Bengal. And of course, just looking forward to hearing you, Raja. Over to you.
Thank you so much, Murli. Thank you for those kind words. I think a lot of work that we have done in bronchiectasis has been with Murli. And I promise you, we'll take you up on your offer to join the Southeast Asian Society for Sleep Medicine by tonight. So that's a promise. I will share my screen and get on with the talk. I'm told that I have 25 minutes, but I know we are a little short of time, so I'll try and finish 20 minutes. What I'm going to talk about today is to talk a little bit about bronchiectasis generally. I'll tell you a little bit about the Indian data, which a lot of you would have heard me speaking about before. And I'll also talk about what is a manual. Where do we go with the management of bronchiectasis? And I would like to make you think about what the future holds for this disease and answer maybe some of the questions which will be answered on the platform a little while ago after Dr. Khushboo Pilania's beautiful talk. So bronchiectasis till about 2014 was recognized as being an increasing clinical problem. If you look on the graph on the right, you can see that the number of patients with bronchiectasis have been going up. The graph is till 2014, but I promise you that the graph has continued to go up even after that. You can see that the numbers increase as the aging population in the world increases. So as the global population becomes more aged, and I'm told India has 1 crore people now above the age of 85 and 1 lakh people over the age of 100. So globally, the population is aged. The number of patients identified with bronchiectasis has increased. The imaging methods that Khushboo spoke about so eloquently have improved. And hence, we are picking up more people with bronchiectasis. And hence, there's been a 40% increase in prevalence over 10 years. You see the European Lung White Book at the bottom on that slide. That's when the mindset about bronchiectasis changed, because that is where the idea of the EMBARK registry globally germinated from. Started off in Europe, it's expanded beyond. And you heard Dr. Murli Mohan and Dr. Khushboo Pilania speak about it, and you will hear me speaking about it as we go along. The reason it's been described in the European Lung White Book as the most neglected disease in respiratory medicine is because they think that it's a waste paper basket diagnosis. You heard the various etiologies of bronchiectasis. I'll tell you some more. But it's been said that too many diseases result in bronchiectasis. Hence, bronchiectasis is a manifestation of multiple diseases rather than being one disease form. In other words, and hence not disease. However, in 2016, when Marx started off globally, all the thought process changed. So data EMBARK follow paper which the EMBARK paper came out last year. One of the things about bronchiectasis is exacerbations. So like COPD, this disease is punctuated by exacerbations, and more the exacerbations, greater the mortality of the disease, less the survival from this disease process. The reason you get exacerbations in bronchiectasis is because of infections. And this is the European EMBARK. I'll show you the Indian data in a moment. But this is the European EMBARK data. And you can see that Pseudomonas aeruginosa, other gram-negatives, Moraxella, Haemophilus influenzae, Staph aureus are the common bugs which colonize the airway and result in exacerbations. The behavior of exacerbations is correlated with prognosis of the disease. And how do you talk about prognosis? There are various scoring systems, but the one which is more popular, the one which is the most validated in India, is the Bronchiectasis Severity Index. And you see the parameters on the table there and the scoring system. I won't take you through the chart, but try and remember the various endpoints that we are speaking about here. You have age, you have the BMI, you have the FEV1, you have the number of hospital admissions before entry into that registry, number of exacerbations before entering the registry, the quality of life measured by the MMRC dyspnea score. Is the patient colonized by Pseudomonas is an important question. Is the patient colonized by any other organism is the other question. And the radiological extent, which you heard Khushboo speak about, are 3 or more lobes involved. And you heard Dr. Murli Mohan saying that cystic bronchiectasis has the worst prognosis. So that's the other question. Is it cystic bronchiectasis? So those are the endpoints which give you the prognosis of patients with bronchiectasis. And you can see higher the BSI score, the worse the prognosis. Note the red line there at the bottom. That's severe when the BSI score is above 7. And in these individuals, the survival is far lesser as compared to mild to moderate BSI scores. And you can see there's a big difference between severe disease versus mild and moderate disease, which are clustered together. Let me take you to the Indian registry now. This is a registry which I was fortunate to lead, and has Dr. Murli Mohan and multiple others on this registry. And we would never have got here 1 sites and about 60 investigators had collaborated for this particular study. Khushboo showed you the etiology slide, but you can see that TB bronchiectasis is one of the common etiology in India. Post-infective comes next, idiopathic comes next. Now, this is an important factor that I want to point out to all of you, which is a thought that we are exploring new MBARC regime, which is to start in a few months. A patient having tuberculosis and a patient having bronchiectasis does not automatically mean that the patient has post-TB bronchiectasis. Similarly, a patient who has a pneumonia and happens to have bronchiectasis years later does not automatically have post-infective bronchiectasis. And of course, idiopathic is a waste paper diagnosis. So the reason I say this is, even if you find a patient with TB has bronchiectasis at a later date, please do not presume that the patient has bronchiectasis from TB. This patient needs to be followed up with investigations that I'll talk about in establishing a diagnosis, an etiological diagnosis aside from TB, and the same stands true for patients who have post-infective or patients who have idiopathic. Why etiology is important? Because in certain etiological conditions, and you can see the etiological conditions in front of you on that slide, treating the cause results in improvement in prognosis of bronchiectasis. It improves survival, it improves outcomes in patients with bronchiectasis. So if you had combined variable immunodeficiency, ABPA, non-tubercular mycobacteria, TB, airways obstruction, inflammatory bowel disease, rheumatoid arthritis, or aspiration pneumonia, treatment of the underlying cause is going to change your outcomes in patients with bronchiectasis. So you would treat the bronchiectasis as a whole, and we'll come back to that later, but you also treat the underlying etiology, both of which changes the natural history of the disease and hence results in better outcomes. This is published in 2022 in neurology, and we looked at 4 different cohorts. We looked at the Korean MBARC data, which is called the KMBARC data. We looked at Lung Australia data. We looked at the European data, and we look at the Indian data. And the reason I put up this slide is, remember I talked about the Lung White Book and the fact that this is a heterogeneous disease. This slide establishes that it indeed is a heterogeneous disease, and we need disease registries to establish the phenotype of the disease in geographies across the globe. So 2 things to look at: the fact that in India, the mean age of disease onset for bronchiectasis is 10 years younger at least as compared to the rest of the world. So you see in Europe, it's 67 years, in Australia it's 73 years, in Korea it's 66 years, for India it's 56 years. And interestingly, this is also something that we found in the ILD India registry, where patients were 10 years younger. So I think an extrapolation could be that chronic lung disease, because of biomass exposure, because of air pollution, happens at a younger age in our population, and we possess more damaged lungs with the passage of years as compared to the rest of the globe. The other interesting aspect about India is that women have less bronchiectasis. The only place in the globe that it happens, women are lesser in number in bronchiectasis in India as compared to the male counterparts. Everywhere else, female numbers predominate. Interestingly, the severest of bronchiectasis seems to happen in Australia. However, the Indian and the Korean cohort show more admissions. This could be the fact that access to hospitals is probably easier in countries like India. However, we also feel that the ones who get exacerbations in India get the severest of exacerbations and get hospitalized. So remember, hospital admissions more in an Indian population. In microbiology, there are 2 factors to remember. One, the fact that like the rest of the globe, Pseudomonas is the commonest bug, even in India, accounting for about 14% of the total positive microbiology in this country. The next important factor is that we have the largest number of Enterobacteriaceae, especially Klebsiella, in our population of patients. About 10% of Indian population of bronchiectatics have Klebsiella. The third important factor is that bugs like Haemophilus, Staph aureus, Moraxilla cataralis, which are common in Australia, common in Europe, hardly happen in India. This could be because it's more difficult to grow these bugs. They are fastidious bugs, and microbiological techniques need to be more robust. And to be honest, with the molecular platforms like BioFire coming in, we have found that we find far more Haemophilus and Staph aureus in our population of patients as compared to what we did with conventional culture techniques. When you look at etiology, we have said post-TB across Asia, especially in India, is the most common etiology. And then we have post-infective, ABPA, idiopathic, and so on. In treatment across the globe, there isn't a licensed treatment for bronchiectasis. So you heard me right. Across the globe, there is not a single therapy which is licensed anywhere in the globe. However, the two areas where there is a lot of evidence is the use of long-term low-dose antibiotics. In Indian registry, we found less than 10% and somewhere in the mindset, there remains the fact that bronchitis destructive is, and we found that only about so I was talking about the evidence-based treatment available in patients with bronchiectasis, and I said that this is one disease where there is not one single licensed treatment for bronchiectasis. However, the most evidence-based treatment we have are low-dose macrolides and inhaled antibiotics. And in both areas, India uses these agents in less than 10% of cases. The other interesting aspect is that patients in India have physiotherapy, or at least an advice for physiotherapy, in up to 40% of cases. However, the most important therapy that's prescribed in India as a part of chest physiotherapy is postural drainage and active cycle of breathing. The devices used normally, so devices like the PEP device or the OPEP device, are hardly ever used in India and should be used with increasing regularity, is something we know about. So when we talk about OPEP devices, there's Aerobica, for instance, which results in sputum clearance at a rate which is much greater as compared to what you would do with postural drainage. However, these complement each other rather than being something which is a replacement for the other one. And it's for all of you to remember these techniques, because we seem to do poorly in the use of these techniques in our country. The other area which I will come to is this publication from last year in 2023, where we published our 4.5-year follow-up data in patients with EMBARK. This again is the same large group which was a privilege to work with. And I'll show you a couple of slides with data from the follow-up of EMBARK. So one of the results that we saw was that there were certain factors which predicted mortality in the Indian registry. One was age. So age above 60 was a strong predictor. Klebsiella infections, so Enterobacteriaceae infections, but especially Klebsiella, was one of the strongest predictors of mortality. Exacerbations and increased exacerbations was a predictor. Cardiovascular and diabetes, cardiovascular disease and diabetes were predictors. Poor quality of life in the way of the MMRC score, and current smoking were all predictors of mortality. What disease had the worst outcomes? And whether it was hospitalization or whether it was exacerbations, patients with the BCOS phenotype, which is the bronchiectasis COPD overlap phenotype, seem to have the worst prognosis, both in the way of having an exacerbation and in the way of hospitalization and mortality. You saw the predictors of mortality. These are the predictors of exacerbations. I said a prior exacerbation is the strongest predictor of a future exacerbation. Pseudomonas aeruginosa infection, you saw Klebsiella and mortality. Pseudomonas is, like anywhere else in the globe, is this one of the strong predictors of an exacerbation. Diabetes, current smoking, MMRC again are overlaps for predictors of mortality and predictors for exacerbation. One of the things that we found both in the European and the Indian registry was that the survival was better than other chronic lung diseases. So while there was a lot of burden of disease, the morbidity of the disease was great. However, the life expectancy in patients with bronchiectasis seemed to be far better other than patients who had cystic bronchiectasis or one of the mortality predictors that we spoke about a little while ago. Let's now come looking towards management. So, and I'll try and talk you through certain bits of the pathophysiology which define where treatment is at the moment and where it's going to go in the coming years. So Murli, I'll take about 5 or 7 minutes more if that's okay, and I'll finish in 5 to 7 minutes. So this is what you see on the left. The circle is called the vicious vortex of bronchiectasis. And I want you to remember this because all of what I'll talk about in treatment is based on this vicious vortex of bronchiectasis. So one of the important factors in bronchiectasis is mucus hypersecretion and ciliary dysfunction. That's what results in the production of mucus and the lack of movement of the mucus within the airway. The airway inflammation in bronchiectasis, different to asthma, is neutrophilic inflammation. So there's T cell proliferation, there's neutrophilic inflammation. This results in chronic infection, and the bacterial virulence factors, which I'll talk about in a moment, result in airway wall destruction, results in the various anatomical variants of bronchiectasis we spoke about, and results in lung destruction, which begets more bronchiectasis. One of the interesting findings which came out in the Blue Journal about 5 years ago was looking at populations of patients who had Pseudomonas and population of patients with bronchiectasis who did not have Pseudomonas. I want you to see this cluster diagram. On the left of that cluster diagram, the green dots are patients who grow Pseudomonas. The ones on the right are patients who have never grown Pseudomonas. Interestingly, patients who grow Pseudomonas have an increased level of an enzyme, which I'll mention a lot going forward, called neutrophil elastase. So neutrophil elastase levels are far higher in patients who have Pseudomonas colonization as opposed to patients who have never grown Pseudomonas. And I want you to see the bar diagram on the bottom left, which looks at neutrophil elastase activity and the fact that exacerbations, the requirement of IV antibiotics, and stability of the disease. So exacerbations, the requirement for IV antibiotics in patients who get hospitalized, and stability or requirement of no treatment depend on the level of neutrophil elastase in these patients. So hold that thought, and I bring you the European Respiratory Society guidelines, which are a bit dated now. We are in the middle of updating the European guidelines as we speak, but these are guidelines from 2017. And this is a treatment algorithm that's picked straight out from the ERS guidance. So we spoke about diagnosis. You heard Dr. Khushboo Pilania speak about HRCT as being a diagnostic tool, the most important diagnostic tool. We look at comorbidities. You look at severity assessment, and I spoke about the bronchiectasis severity index in that perspective. When we talk about management, there are 4 heads or 5 heads under which we speak about it. One is treatment of the etiology, the treatment of the cause, and you heard us speaking about that. The second is improved clearance of the chest, and you heard me speaking about physiotherapy, postural drainage, active cycle of breathing, OPEP and PEP devices. Next is control of infections. Next is control of lung function, and last is control of complications. I won't speak about these in details, but when you think about management, when you see your patient with bronchiectasis, make sure in your head you've ticked the boxes. Have I found out the cause? And if I have found out the cause, have I treated the cause if it's treatable? Have I spoken about chest physiotherapy to my patients? Have I thought about the use of low-dose macrolides or the use of inhaled antibiotics in my patients with bronchiectasis if it's relevant? Have I thought about bronchodilators or inhaled corticosteroids in the relevant population of patients? Have I thought about controlling complications, like thinking about the patients with massive hemoptysis who require embolization or a multidisciplinary approach? If you do these 5 things, you control the 3 endpoints of bronchiectasis which you need to control. One is improving quality of life. The second is reduction of exacerbations and hospitalization. And the third is reduction of mortality in these patients. So the ERS recommendations for patients, management of patients with bronchiectasis, the pharmacological treatment in patients who have 3 or more exacerbations needing antibiotics is twofold. One is use of long-term inhaled antibiotic therapy, and the other is long-term macrolide therapy. Now, when would you use long-term inhaled antibiotics first up? It's in patients who grow Pseudomonas. When would you use the long-term macrolide treatment first? It is in patients who have not grown Pseudomonas. So remember that that's easy. In patients who grow Pseudomonas, you think of an inhaled antibiotic. In patients who have no Pseudomonas, you think of long-term macrolides. And these are interchangeable. Patients on low-dose macrolides can go on to long-term inhaled therapy. Patients on long-term inhaled therapy can go on to long-term macrolide therapy. Why are we doing this? The reason we do this is we know higher the bacterial load, more frequent the exacerbation, and more the number of unscheduled hospital admissions. You can see on that slide, as the colony counts go up, the risk of exacerbations and the risk of hospital admissions go up. The other interesting factor, which is shown in this very neat study from the Blue Journal, is as the bacterial load goes up, and you can see the green line at the top there, higher the bacterial load, greater the response to the inhaled antibiotics. So in your patients who grow 10 to the power of 6 Pseudomonas, for instance, on a sputum culture, the chance that there'll be a response to an inhaled tobramycin or inhaled colistin is far greater as compared to has a lower colony count. That's another thought to hold in your head. The other important factor is if you reduce bacterial load, your symptoms improve. This is looking at the Orbit study with inhaled levofloxacin. And while this was a negative study, it did show that patients who were on an inhaled levofloxacin did much better in the way of symptoms as compared to patients who were on a placebo. This is 2 different meta-analysis, and it establishes the 2 points that I was discussing. The fact that use of inhaled antibiotics, tobramycin or colistin, across 2,500 patients, various 16 different trials, shows a reduction of about 19% in exacerbation rates, and the use of low-dose macrolides across a similar number of patients shows a 50% reduction in exacerbation rates. 20% for inhaled antibiotics, 50% for low-dose macrolides. So those are the 3. These are 2 meta-analyses which got published in 2022. So take-home messages from those 2 papers: macrolides work, and they are superior to any other treatment available in bronchiectasis till date. Inhaled antibiotics work, but they do so in patients where there's a higher bacterial load. And new therapies are coming, which I'll speak about as we finish off in the next couple of slides. So remember, we spoke about inhaled antibiotics and low-dose macrolides, and we spoke about neutrophil elastase. So this is looking at endotyping. Greater the amount of neutrophil elastase, greater the neutrophilic inflammation, greater the lung destruction, greater the exacerbations, greater the hospitalizations, greater the mortality. So neutrophil elastase seems to be the molecule to target when you think about changing prognosis in patients with bronchiectasis. About 20% of patients with bronchiectasis have blood eosinophilia similar to what you would get in asthma. And in these patients, the patients with a blood eosinophil count of more than 300, inhaled corticosteroids seem to work. In the remaining population, especially in patients with a low eosinophil count, below 100, inhaled corticosteroids cause more of pneumonia, analogous to what you get in your patients with COPD. So that's another important factor to remember. So that's an algorithm I want you to remember. Your patients with bronchiectasis exacerbations, think about airway clearance, think about macrolides. That's for all your patients. In treatable traits, if your patients have an increased bacterial load, think of inhaled antibiotics. If there's mucus plugging, try and use mucolytics and mucoactive drugs, including hypertonic saline. If your patient has blood eosinophilia, hence a eosinophil inflammation, think of inhaled corticosteroids. So the last 2 slides as to where we are going. I spoke about neutrophil elastase. This is a trial which looks at a DPP1 inhibitor, which is an antagonist for neutrophil elastase, a molecule called brensocatib. So what does brensocatib do? It reduces neutrophil elastase and other enzymes in the lung which cause lung destruction, like proteinase 3 and cathepsin G. So antibiotics might not be the way forward in patients with bronchiectasis, and I've put this slide in. I think they might be similar to what SABA is for asthma today. So what you're doing is treating infections as they come. However, the lung destruction continues despite using short courses of antibiotics. So what you want to do is to reverse the neutrophilic inflammation in these patients, and molecules like brensocatib and others will probably do that as we go forward. We know that as you reduce neutrophilic inflammation, the quality of life gets better, exacerbations reduce, and that's probably where the future of bronchiectasis treatment lies. I'll finish off with this slide. I spoke about the fact that a lot of patients labeled as post-infective, labeled as patients having post-TB bronchiectasis, probably have things like ciliary dyskinesia, other genetic causes of bronchiectasis, and that's what we need to explore going forward. So that's my finishing slide. I think it's great that we have got consensus guidelines now. We've got Indian guidelines which are on the anvil. There's better clinical care available with drugs, with airway clearance techniques, with risk assessment tools, prognostication tools available. There's sharing of data registries throughout the globe, and I showed you some of the comparisons of data throughout the globe. And I think we have started understanding neutrophilic inflammation, the nature of inflammation in bronchiectasis a little better. And we are individualizing treatment. So we spoke about inhaled corticosteroid in patients with eosinophil inflammation, antibiotics, macrolides in patients with non-pseudomonas airway inflammation, and inhaled antibiotics in high bacterial load patients with pseudomonas growth. So we are doing precision medicine in doing that, and we are trying to facilitate research throughout the world. And I think going forward, we will see a lot more of this and better management of this disease, which was once called an orphan lung disease. Thank you very much, and I'm sorry I have run over time.
Not at all. It was a pleasure, as always, listening to you, Raja. And I know you have to leave in 10 minutes. So with the permission of our other panelists, I'm going to ask Raja a few questions and we'll let him run away. Raja, first question to you. How commonly do you see bronchiectasis in your practice? You use the term orphan disease just now. Is it still an orphan disease, or are we well away from that?
No, I think, Murli, we have moved away from that. So one of the titles of the talks given to me often is bronchiectasis no longer an orphan lung disease. So I think increasingly, bronchiectasis is a diagnosis which has become prominent in a lot of our heads. You know, when we see patients with COPD, when we see patients with asthma, we often think, does this patient also have bronchiectasis? Is it one of the overlap syndromes, as they are commonly called? Or when a patient comes with coughing up sputum, at one point of time, we would only think of this being the chronic bronchitis phenotype of COPD. Probably now there's been a paradigm change, and we think this is this bronchiectasis. So I think I see bronchiectasis very often, which is no wonder because that's my area of passion. But I think for all of us, people on this platform and people listening in, it has become a disease which is common, and it's important to diagnose it because, like we said, you can actually change outcomes of the disease process by diagnosing this disease early.
And following the guidelines appropriately.
Yes.
So, what kind of bronchiectasis do you see in your practice? In the Embark India, we thought it was TB and other post-infective conditions. Is that true even if you have a specialized bronchiectasis clinic?
It isn't, Murli, and this is something that we are looking at, as you know, for the follow-up study of Embark. So we feel that a lot of patients with post-TB bronchiectasis got a label because TB is such an endemic disease in India. And they never got investigated further because there was coexistence of TB and bronchiectasis in the same patient rather than being post-TB bronchiectasis. One of the things, and I think you will ask, I think Khushboo got asked this question a little while ago on the chat. How common is ABPA in India? So we only tested for ABPA in 18% of the entire lot of patients with bronchiectasis in our registry. Out of this 18%, 50% of these patients actually had ABPA. So whenever there's a high suspicion, index of suspicion, 1 out of 2 patients have ABPA. So what we have recommended in the Embark study is that everyone should get tested for ABPA across bronchiectasis categories. And I think across the country now, we no longer believe that this is a Northern Indian disease as we used to think before. It might be more common in Northern India, but we know it's something which is prevalent throughout the country. And more we diagnose, the more we look at it, the more we diagnose. The other disease which I see much more now is PCD. So we have the capacity now to screen for PCD. And a lot of these patients might not have PCD, but have ciliary dyskinesia. They have nasal nitric oxide levels, which are analogous to what you would expect in patients with PCD. So I think these are diagnoses that we'll get to. And I don't think all of the labels of post-TB bronchiectasis or post-infective bronchiectasis are actually those. They might have had a pneumonia and then had bronchiectasis, but there are other etiologies attached which we need to investigate because we can change the long-term outcomes in this disease.
Dr. Manu Mohan asks, a related question. He says, can tuberculosis be considered as a probable etiology in a case with lower lobe bronchiectasis?
Yeah, so that's an interesting question. And our registry shows that the incidence of bronchiectasis across lobes is very, very similar. But I think Dr. Manmohan is probably right, because a lot of these patients probably do not, the lower lobe ones probably were not TB, they had TB and coincidentally also had bronchiectasis. We know from the Korean registry and the Chinese registry that for them, the right upper lobe was the commonest site for post-TB bronchiectasis. And that's something that we have seen even in the European cohort of patients, which are smaller in number, but still there's a percentage of patients with post-TB where the upper lobes are more prevalent. So while our Indian data does show that it's the same across lobes, that's probably slightly misleading data. As we go along, we'll probably show that it's more upper lobar disease rather than lower lobe disease.
Right. I've got a few of my own questions for you. Just a comment, maybe we're also diagnosing bronchiectasis more frequently because of better, more widespread use of CT scans, which is so important. And of course, another comment was, when you find bronchiectasis, look for the comorbid COPD because that significantly worsens outcomes. But my specific question to you, Raja, is do you use the scores, the bronchiectasis severity index or the FACET score in your patients with bronchiectasis when you're clinically managing them?
Yeah. So a quick comment about the CT, Murli. So, and I would also like to pick your brains as to what you think about this. So we spoke about patients who have a phenotype of bronchiectasis when we were speaking a little while ago to Khushboo. There are some patients with bronchiectasis where you incidentally pick up a dilated airway, which obeys the definition that Khushboo spoke about a little while ago, but probably does not have symptoms of bronchiectasis. And I personally would not treat these patients. So I think it's important to remember that it's not just a CT which defines bronchiectasis, it's a symptom plus a CT plus the microbiology which together defines the disease. And hence, picking up bronchiectasis on a CT is good, but you need to make sure you correlate them with symptoms before you start treating them as bronchiectasis. So that's one comment. The other is, do I use BSI and FACET? I do, Murli, because one of the reasons is because all my patients actually have been going into the registry and I've been following them up. So it's a compulsion that I have. Would I otherwise use it? I think it helps. I think the BSI is not difficult to do. And if we do that as a matter of routine, it probably helps in the long-term prognostication of these patients and management of these patients. So I would strongly recommend all of us do that in clinical practice also.
And really what the EMBARK data showed us is that many of the criteria in the BSI or the FACET are the risk factors that, you showed.
Sure.
So I think we should be using a score, get a little more objective about it. And finally, we always talk about Pseudomonas, but what we have seen is and that again emerges from EMBARK, is that Klebsiella in India is extremely important. So should we be treating Klebsiella the same way, down the same, algorithm limb that Pseudomonas does in India? So that's something we should explore.
Yeah. So I think, Murli, that's a very, very pertinent question. We will hopefully answer that question in the second part of EMBARK. But even without an answer, I think there is absolutely no harm in extrapolating the data that we have for Pseudomonas to all Enterobacteriaceae, including Klebsiella. So we have data to show that the presence of Klebsiella even once in the sputum of patients with bronchiectasis increases mortality in our cohort of patients. That is for sure. And it does so more than what it happens in case of Pseudomonas. So to try and eradicate that bug and improve prognosis, I think is a no-brainer. And I would definitely do that for all my patients, even before we generate the data.
And one last question before we let you run away. When do you ask for special investigations to diagnose the underlying cause, which is so important? cause of bronchiectasis? And in this case, what tests do you do? What are the basic tests you do? And when do you ask for more advanced tests?
Sure. So what would I do in all my patients? I would do a complete blood count, and I would make sure that I look at the eosinophil count in these patients. That's number one. The second thing that I would definitely do is to do a sputum. I would do a gram stain. I would do a culture, and I would do a CBNAT or a gene expert in these patients. So I would look for both NTM and I would think about TB. You need to think about both these entities. The next thing I would definitely do is to do an IgE for Aspergillus antibody. That's something I do, and that's your screening test for ABPA. If your IgE for Aspergillus is negative, then you can safely rule out the sensitivity of the test is to the tune of 96%. So you would almost have completely ruled out ABPA if you do that one test in ruling out ABPA. The other test that I would do in most of my or all my patients is to look at the immunoglobulin panel, because I forgot to mention CVID or immunoglobulin deficiency is a far more common disorder in our country as compared to what we used to think 5 years ago, since we have the registry. So I would do an immunoglobulin panel. The other thing I would do in a lot of my patients is to look for things like collagen vascular diseases. So I would do an RA, I would do an anti-CCP, I would do an ANA in these patients. We also know that patients with rheumatoid arthritis who have bronchiectasis actually have a prognosis similar to the COPD bronchiectasis overlap. And that's also from the EMBARK data. So that's also something very relevant to look for in Indian population. So once you've done that gamut of tests, you would have covered a lot. We would have covered 80% of your bronchiectatics. In other specialized centers, you would think of doing things like nasal nitric oxide to screen for patients with PCD. If you find a familial history, there are certain genes that you need to look out for, and you could do a genomic analysis in these patients. But I think the first set of investigations that we talked about are easy to do. They're not very different to what you would do in your patients with ILD for a basic screen. So I think it's similar to that. And if you think of it like that, as a package of tests that you do for your patients with bronchiectasis, you would get the etiology in more cases than not.
Thank you so much. I know you have people waiting for you. Very grateful for the time you spent with us, and have a wonderful rest of the day, Raja. We'll let you go away now. Thank you so much. So,
thank you.
Yeah, thank you very much, Murli. I will be logged on for another 5 minutes and then I'll log out. Thank you very, very much for having me. Thank you very much.
So let's go on to introduce the rest of our wonderful panel. And we have close to 1,600 logins. The first is another dear friend, Dr. Parvaiz Koul, Professor of Pulmonary Medicine and former Director of the Sher-e-Kashmir Institute of Medical Sciences in Srinagar. He is a fellow of the Royal College, the European Respiratory Society, has a fellowship in pulmonary critical care and sleep medicine from the United States. Over 500 publications. His H-index is 75. He's got over 97,000 citations. So we are in the presence of publishing royalty here. Multiple memberships and fellowships. He's the chief editor of Lung India. So that's where you'll see him with his name in every single issue. And earlier, before he became an editor, we'd see his name in frequent papers in the Lung India. He's my go-to person, the person I respect most when I need any information on vaccines. Multiple awards, I'm not going to list them. And as always, Dr. Koul, it's an absolute pleasure to have you on a panel, and we look forward to learning a lot from you.
Thank you so much for your
next panelist is Dr. Savita Jindal. She's currently the Associate Professor, Head of the Unit in the Department of Respiratory Medicine in the Narendra Modi Medical College. She's a Governing Council member in the Association of Chest Physicians of Gujarat, a member of ICS and NCCP. Multiple national and international journal publications and presentations, as well as guest lectures. Her special interests are in the areas of obstructive airways disease, interventional pulmonology, pleural diseases, and TB. Welcome, Dr. Savita. Looking forward to hearing a lot more from you.
Thank you, sir.
Another panelist, Dr. Kranti Garg from Patiala in Punjab, an MD Medicine from 2010. She's now an associate professor in the Department of Pulmonary Medicine in Punjab, the Government Medical College in Patiala. Has been in other departments earlier, the Government Medical College and Hospital in Chandigarh. multiple memberships, more than 40 conference publications, more than 50 publications, book chapters and journal articles. She's a frequent reviewer as well as an editor for various journals. Multiple awards, the Gurukul Citation Award on International Women's Day earlier. And her special area of interest is an area I think more of us should be focusing on, psychological suffering associated with respiratory disease, an often neglected area, interventional pulmonology, and another neglected area, very, very important area, medical ethics and education. Welcome, Dr. Kranti.
Thank you. Thank you so much, sir. Thank you, sir.
And our last panelist this evening, Dr. Tarang Kulkarni from Thane in Mumbai, I should say, DNB Respiratory Medicine, MRCP UK and the SCE, and the Association of Respiratory Medicine from Paris and France. He's currently associated with Jupiter Hospital in Thane and has multiple awards, G C Khilnani Young Scientist Award, the first prize at the National All India Pulmonology Quiz at NAPCON. I wonder if I was there as one of the persons contributing the quiz, which I think Raja did that year, and presentations at the ERC Madrid, and multiple book chapters, 13 publications, 5 book chapters. So we have a very distinguished panel with us today. I don't know if Dr. Khushboo is also here. If she is, Dr. Khushboo, I'll invite you to come in on some of the questions which involve radiology. Please feel free.
Yes, sir, I'm around, sir.
Great, Dr. Khushboo. If you can join us on some of those, please feel free to push in, ask questions at any time, and contribute to the topic being discussed. And that's true for all the panelists. We have about 45 minutes more. We will be stopping at 10:30. I'll be starting with a few questions.
Only before you move on, can I
Yes,
just, before I escape, have the pleasure of introducing you? I don't think we've done that. So before I run away, if I can have the pleasure of introducing my dear friend, Dr. Murli Mohan. He's spoken about us. So I think it merits mention that Murli is popularly known as the Einstein of respiratory medicine in India. So he combines all the clinical, the academic, the research hat, all of that and more. He's probably the pulmonologist most looked upon by youngsters throughout the country. And you heard about the quiz that Tarang was a part of. You definitely were a part of that quiz, and you contributed like you always do for our NAPCON quizzes, Murli. So currently Senior Consultant and Academic Director, Department of Internal Medicine and Pulmonology at the Narayana Health Mazumdar Shaw Medical Center in Bangalore. He's the Professor and Head of Department of the B.R. Ambedkar Medical College, Bangalore. I think he's got 6 orations, but he probably will continue to do many, many more. I'm sure he has done multiple orations that are not mentioned here. Many book papers, posters, national, international journal conference presence, chapters in 5 books. He's a joint author of the WHO Manual for Tobacco Cessation for Doctors and Dentists, and author of the Manual of Basic Life Support, and founder Nightingale Saving Services, and has to date trained over 90,000 people in CPR in Karnataka. I mean, that's absolutely amazing, Murli. Hats off. Areas of interest are ILD, pulmonary vascular disease, but with Embark, I would probably say that there's also bronchiectasis in that list. And special abilities and talents are multiple. He's been modest there, but he is a very avid quizzer, and we would not have the NAPCON quizzes without contributions from Murli every time. So thank you, Murli. I'll hand it over to you. And thank you for always being there for us.
Very kind introduction. Yeah, I'm particularly proud of the 90,000 plus people we've trained. I think that's, if there's one contribution I'm very proud of, it's that. Thank you. So let me go on to the questions. And Raja, as long as you're here, please feel free to come in. Dr. Parvaiz, is there a classification of bronchiectasis? We've heard briefly about it, but tell us a little more.
So Murli, once we talk of classifying bronchiectasis, multiple people have done it in a variety of ways. And the most commonly used and most frequently used is the one by Reed, which was alluded to by Dr. Khushboo Pilania also. which is an anatomical classification. We call it a tubular, we call it circular, and cystic with the description as given by Dr. Khushboo. And we, apart from this, which is the most frequently alluded to, people have tried to classify bronchiectasis on the basis of etiology. Say, some believe that it is CF versus non-CF bronchiectasis. One group would be cystic fibrosis, and everything else is non-cystic fibrosis. Some people believe that you can divide it into, say, congenital and hereditary disorders and everything else. So I would say that the one classification that has actually stood the test of time is the one that Dr. Khushboo talked about. It's the Reed classification. We divide it in on the basis of CT findings into cylindrical bronchiectasis, varicose bronchiectasis, and cystic bronchiectasis. And as you rightly said, that it is also a measure of severity, with the cystic bronchiectasis having cystic spaces and honeycomb appearances as being probably the worst in terms of prognosis.
Thank you. And my next question is to Dr. Savita. Dr. Savita, what symptoms specifically make you suspect bronchiectasis? Because there's often a big lag between, the patient first having symptoms and the actual diagnosis being made. So what symptoms and what signs do you look for in a patient with bronchiectasis?
Yeah, as in his talk, Dr. Raja sir has said that symptoms are more important, because sometimes patient presents with symptom, but it has not been picked up by the CT also. So patient usually comes to us with production of sputum, which is usually sometimes yellow and having more frequent sputums. And sometimes patient have more pulmonary infections. Some more commonly these are pseudomonas. And in the patient, those who have been diagnosed as COPD, but which was a non-smoker variety, but have repeated exacerbation. In that cases also, we can think about that patient may have a bronchiectasis. And if the patient presents to us of a history of recurrent hemoptysis also, all these are mainly the symptoms in which we can suspect that patient may have bronchiectasis. And if we talk about the clinical signs, usually these patients, because of repeated infections, they may have clubbing, and we auscultate the patient, then they have usually coarse crepitation, which we call it as a leathery crepitation. And if the patient have obstructive airway disease along with it, maybe COPD, then patient may have rhonchi also. So these are the common symptoms and signs in which we can suspect bronchiectasis.
I'm actually going to go on to ask you and any of the others. Dr. Santosh, first of all, Raja unfortunately seems to have left, but he first said wonderful talks. So Dr. Khushboo, appreciation from the audience also. And they said prolonged use of inhaled corticosteroids in chronic asthma. But when should one start thinking about bronchiectasis? And how often should you screen a patient for the same? So when do you start thinking? You already, I think, answered that question largely. But how often would you screen the patient for the same?
Sir, are you asking me?
Yes, you or anybody else. Anybody can
come
in since...
So, it's like the patient, like when we are suspecting bronchiectasis, like then we have to sometimes do specific investigation. Like Raja sir has said that we should see what are the underlying etiology also. So when we are sending the patient for eosinophilic count, and if it is more and his inflammation is more, in that patient we can start inhaled corticosteroids in these patients for that. But if the patient neutrophilics are more, then we should not give inhaled neutrophilic steroids.
Right. Thank you. Nobody else wants to come in on this. I'll go on to the next.
Can I comment?
Yeah.
So I think a brilliant question. Sir, in all patients who are even in our severe asthma algorithm, there is a place for getting a CT done to rule out coexistent bronchiectasis. Now we are just not thinking about ABPA, but we are also looking for other form of bronchiectasis that potentially could coexist with asthma, something that is popularly ABO or the asthma bronchiectasis overlap. So I feel vice versa, all patients of severe asthma not adequately controlled on inhalers should generally get a CT done to look at coexistent bronchiectasis. And that also has been the understanding with the COPD bronchiectasis overlap, with the old guidelines focusing more on CT as one of the additional investigations to rule out coexistent bronchiectasis.
Absolutely. Completely agree with you. So
And
people who
I'll
are
add,
poorly
sir.
controlled. Sorry, Dr. Kranti, please go
Yeah, I
ahead.
think I'll add in such patients of bronchial asthma, like severe we are talking about now. I think for particularly for ABPA, we should screen these patients first with a specific IgE. That will be a very good test so that we can proceed on to a HRCT.
Absolutely. So the clues would probably be when they're not very well controlled, too frequent infections, too frequent exacerbations, something is not right. They're not responding to the treatment that is as you'd expect. Start thinking of a comorbidity like bronchiectasis, whether it's asthma or COPD.
Absolutely.
Right? So my next question, I think, is to Dr. Kranti. Dr. Kranti, Dr. Khushboo has already taken us excellently through this, but when you suspect bronchiectasis, which is the gold standard investigation that would confirm your diagnosis, and again, for your people who may have logged in late, what are these classic findings that you see?
Thank you, sir. So we have moved from the days of chest radiography and bronchographies to CTs, and maybe MRIs could be the future. But right now, the gold standard investigation is a HRCT chest. And as Dr. Khushboo has already told, the classical features in CT chest, which we will get, first of all, is the AA ratio. That is the airway artery ratio will be more than 1. We'll be having an irregular, wide and thickened bronchial walls. There will be lack of bronchial tapering, which we usually see otherwise in normal individuals. And the bronchi will be visible within 1 to 2 centimeters of the pleural surface. That is, these are the classical features which will help us diagnose bronchiectasis. And when we talk about chest x-rays, which are very commonly used in our OPDs, then features like finger in glove appearances, tram lines, toothpaste shadows, they all can be pointing towards our further investigations.
Absolutely. And I think that answers one of the questions our audience were asking. What are the named signs in bronchiectasis? Of course, the other one which reflects the AA ratio is the signet ring appearance. Would either of you like to add anything to that list? Any named signs, radiological signs in bronchiectasis?
Tram
lines, we have
Tram tracks.
Yeah, Dr. Khushboo, go ahead, please.
So the tram track sign, the lack of tapering of the bronchus, so that's one of the named signs.
Then one is signet ring appearance also.
That sir already mentioned the bronchoarterial ratios, that becomes the signet ring sign.
Yeah, so those are, anybody else has any to add? Because I think
there was one question on pseudo bronchiectasis as well.
yeah,
So
can you
yes,
go
we
ahead and
have to
answer that, Dr.
differentiate
Kranti?
because we have to see for the like the arterial diameter can itself be lesser. So we have to be careful that whether it is a bronchiectasis, because if the arterial diameter, for example, because of any vasoconstriction, for example, in patients living in high altitudes, in smokers, the arterial diameters may be less. So there may be a pseudo bronchiectasis. That is the AA ratio will increase, but actually there will not be any bronchiectasis. So I think Dr. Khushboo can add on to what I'm saying.
Usually in these cases, those can always formed. So when we are looking at a lesser arterial diameter, there is often associated small airways components. That is something we need to rule out. At the same time, yes, very rightly said that also in case of chronic pulmonary thromboembolism, there can be areas where these diameters are and if we are seeing an airway which is more prominent or dilated, it should be seen with caution. So those things we have to keep in mind.
Thank you.
So one more, sir, can I add something?
Yes, Dr. Tarang, and then you can go on with, once you've confirmed a diagnosis of bronchiectasis, what initial investigations are necessary in these patients?
So I think CT also adds to the fact that it could help us understand what is the primary cause of the bronchiectasis. So the pattern of distribution also is extremely important. So for example, an upper lobe predominant bronchiectasis, you would think of a post-TB or a cystic fibrosis associated bronchiectasis. You would think about NTMs or Lady Windermere syndrome, as popularly known as, in patients who have a right middle lobe bronchiectasis, for example. And all the other variants like primary ciliary dyskinesias, all would be distributed in the lower lobes. So I think that is also something that would give us how CT would help us to give us an insight into what the potential etiology is. And so to answer the second question, If I have a patient with bronchiectasis, I think the ERS guidelines has given a proper bundle of investigations which has to be done, which Dr. Dhar also talked about in his talk. The first is a complete blood count to look at two things. One is the eosinophil level, of course, and the second thing is to look at the possibility of having a leukopenia or a lymphopenia, which potentially could suggest some sort of an immunodeficiency. I would do immunoglobulin levels, so IgA levels, IgG and IgM levels to look at common variable immunodeficiency. And of course, the Aspergillus panel, that is a total IgE level and Aspergillus specific IgE and IgG to look at and to rule out patients with EBPS, because all of these are potential treatable traits in bronchiectasis. And if with all of this investigation, if the history suggests that there could be a potential connective tissue disease or any other correctable trait, I would be inclined to send a CTD marker analysis.
In fact, we find more and more often that we are missing out on the CTD. So it probably is something I would have a very low threshold for asking for the CTD workup in these patients, especially as you said, low predominant disease, some degree of fibrosis here and there. Then I would certainly ask very early for a rheumatoid factor, anti-CCP, and the anti-nuclear antibody. Thanks, Dr. Tarang.
Yeah.
Dr. Parvaiz, bronchiectasis and comorbidities. We partially discussed it already. In your practice, what common comorbidities do you find with bronchiectasis? And are there anything you specifically look for in a patient with bronchiectasis?
So thanks, Dr. Murali. Yes, we talked about it. We have to understand that bronchiectasis is a complex, it's a multi-component disease characterized by systemic inflammation, which is chronic. Frequently coexists with comorbidities, whether they are underlying cause of the bronchiectasis, may exist in synergy with the bronchiectasis, or may be coincidental. I would allude to one previous study by McDonald in 2016, who said that people with bronchiectasis diagnosis on an average have two to six other conditions. And the most common conditions are respiratory conditions, cardiovascular conditions, gastroesophageal reflux disease, psychological illness, pulmonary hypertension, and cognitive impairment. If I go to the study that you actually were part of, the EMBARK study, you know that comorbidities that were identified were cardiovascular disease, then patients had asthma, COPD, diabetes, probably surrogate for the high prevalence of diabetes in the country. Then there were osteoporosis, liver disease, and depression and anxiety. So there are a number of comorbidities that are associated with bronchiectasis, either in synergy or coincidental. And there are lots of studies that have been done in the world have found that comorbidities are coexistent. What I'm bothered about is most of the times is a patient, as you rightly said, of asthma or COPD not doing well. I would like to actually sift through the CT scans and try to figure out if there is any evidence of bronchiectasis. And many a times I'm surprised that bronchiectasis is the cause for poor response of the person to his treatment. Yes, those are the ones that I actually look for bronchiectasis in. And I would also try to find out if there is any other comorbidities, specifically the cardiovascular comorbidities that exist in a patient with bronchiectasis.
And that has a huge impact on outcomes and your plans for the future.
Absolutely.
I'm going to come back to Dr. Kranti at some point, because Dr. Parvaiz referred to anxiety, depression as being common comorbidities. And that's something we hardly ever look at. One of my areas of interest again. So I'm going to come back to you right at the end, Dr. Kranti. But now I'm going to go on to Dr. Savita. Dr. Savita, are sputum cultures useful? How often do you do them? And when you do them, what organisms do you commonly find in patients with bronchiectasis?
Definitely cultures are of course helpful because these are the mainstay of treatment. For bronchiectasis, we have repeated exacerbation in the patient. So when we do cultures, we'll be able to having what pathogen it is, because sometimes there's dominant pathogen and sometimes in the past exacerbation, same pathogen is there. So we'll be able to find out which organism is colonizing that patient. So because if it is Pseudomonas, so which is very difficult to eradicate, then we have to, our pathway for treating that patient will be different than the non-Pseudomonas. And this will see what the dominant pathogen mainly is the Pseudomonas, But as we'll see in India, as Dr. Rajadhar also has said, that Klebsiella is the more common in India as compared to the European countries. But other like H. influenza, Staph aureus, all these are also dominant. But in some cases, there may not be any dominant pathogen also. And if we'll see the frequency, like depending upon the symptoms also. So if the patient is having a repeated exertion, then at every exertion we can do that culture also. And if the symptoms are severe, then also we have to repeat it.
Absolutely. A change in the sputum also should determine, when. So you have patients who are very closely involved with their self-management. They will send a sputum culture before they even come to you. And I think that's very useful. You need to educate them, because having a culture early, otherwise you'll have to wait 2 to 3 days before you can, respond to the change. But having a previous culture often determines that you can start empirical treatment straight away. So yes, I think we need to do that. And of course, it's not only Klebsiella. We are also seeing some of the others. A lot of the time we are seeing Acinetobacter, for example.
Yeah, Moraxella also we are seeing.
Moraxella. Yeah. So Moraxella doesn't worry me so much. The others are often very difficult to handle, but handled early, you find that a very good sensitive bug persists for a long time. So again, in COPD, we found that exacerbations are often associated with the change in the bacterium. Any of our panelists, do you see the same thing in bronchiectasis, that a new bug seems to cause exacerbations?
Yeah. See, it's not like that. Sometimes I have so many patients for bronchiectasis. Usually 50% of the patients, they come with the same pathogen, but sometimes there may be a new. So those who are very chronic patients, they usually know by their symptoms. And sometimes in some of the patients, they start taking antibiotic by their own, like last time I've taken that and they're getting better. But if we'll see, if the change of color of the sputum, it is there may be some new organism also. And by the color also, like if it is green, then we are usually come to know that it is Pseudomonas. And if it is current jelly type, then it can be Klebsiella. So Klebsiella and others are Pseudomonas are more common. But there may be same, or it can be a new bug also, like both ways.
Which brings me on to the next, patients not getting better. Very often we are missing the bacterium. And one of the things, Raja also referred to it earlier, is mycobacterial and the non-tuberculous mycobacteria. So Dr. Kranti, how often do you ask for mycobacterial and fungal cultures in patients with bronchiectasis? And really, when you ask for them, how often are they positive?
Yeah, I think like we have already discussed, the patients who are not responding to our standard therapies, the patients who are having any radiological deterioration, there is a rapid, otherwise clinical deterioration, there is a weight loss, hemopsis. In such patients, yes, we suspect NTM. And these patients require the cultures to be sent for NTM. And another important thing here is that since under the guidelines, when we are treating bronchiectasis, we are planning long-term macrolide therapies for our patients for Pseudomonas. So long-term macrolides, they are very effective, one of the drugs for NTM. So in such patients also, yes, we need to rule out NTM first. Otherwise, monotherapy may harm these patients rather than doing good. And when we talk about fungal, what the literature says about fungal is that many of the patients have colonization with Aspergillus and Candida, and they are isolated from the sputum of the patients of bronchiectasis. However, even after isolation, their clinical significance is not much known. So we have to be very careful when we start these patients for treatment. And when we talk about the percentages, the literature says that Aspergillus could be isolated from as far as 9 to even 57% of the patients. They had Aspergillus cultures positive. And when we talk about Candida, it was to the tune of 45%. So in patients who are on steroids, and particularly the patients who are having unusual patterns of exacerbations, or the patients who are on long-term antibiotics, yes, we can think about fungal etiologies, but again, stressing the same point, their clinical significance needs to be elucidated further before we treat each and every patient for fungal.
Absolutely. And ideally, even with non-tuberculous mycobacteria, you want at least 2 cultures.
Yes.
Showing the same bug. Don't react to a single culture if it doesn't clearly fit your clinical picture.
We may need to go for bronchoscopies in such patients and take lavages and see whether NTM is positive.
Absolutely.
Okay. Can I ask a question, sir?
Yeah, please.
So I agree with what Dr. Kranti said. Now, the problem here is that something that we face a lot in the clinical scenario is patient whom we suspect that it will be NTM infection. You do a sputum or a BAL, and which comes out to be AFB positive, but turns out to be a gene expert negative. Now, you have to wait till the time the AFB culture matures. Now, we are lucky if it is a rapid grower, you get an abscesses at the end of maybe around 10 to 14 days. But in the meanwhile, when you have this scenario and she's waiting for the AFB culture, what regimen do the experts, like all of you, follow? Do you go for the conventional MAC regimen, or because we have rapid growers that are more common in our scenario in our hospital or anywhere? So would you go for that particular NTM regimen?
So, Dr. Kranti, you want to take that? Is it TB or NTM?
First of all, we'll have to rule out whether it is a colonizer or it is actually the reason. So we have to look into the clinical scenario of the patient itself. And like I have already told, that if the patient is radiologically deteriorating, clinically deteriorating, how strong is our suspicion for NTM to be the cause of those complaints? So then only we can think about treating. And then obviously we will be treating with the regimen which we are thinking that the most likely, like you are saying that you have rapid growers. So you will be thinking about treating MAC. So that will depend upon what you are thinking in that particular patient, depending upon his history, his clinical features, his radiological findings, everything.
So, can I say something?
Yes,
we cannot go by a single smear. Like if just a sputum smear is positive and the CBNAT is not showing MTB, so that does not mean that the patient needs to be treated for NTM. Single smear that does not have any value for NTM. When if we are thinking about treating NTM.
Yeah, but Dr. Kranti, these are patients with bronchiectasis. These are patients with bronchiectasis who already have. So already your suspicion, you're sending a AFB culture here because the index of suspicion is high in this case. Okay,
So
and
under the guidelines, we need three sputum.
The guidelines say that you would have a single BAL is enough. You don't actually have to have two different sputum samples. And all of us actually, I think so, follow up that sputum with a BAL to make sure that our suspicion is on the right track.
So single BAL, but cultures, 3 cultures for NTM, even in bronchiectasis. This is what the guidelines say. I think Dr. Savita wanted to add something.
Yeah. I just wanted to say, we'll see, as you told, that we see the clinical scenario of the patient also. See, if the repeated sputum is positive, so according to the guideline, in that case, we can send the LP also. If that also is also negative, means the patient is having disease with the symptoms are also present, but it is not tuberculosis, like Mycobacterium tuberculosis, maybe something else. So bronchiectasis patient is not getting better with the antibiotics and not getting better with the all other primary treatment, then we can think that it is. So because the culture is always taking time, sometimes it is taking 42 days if it is not having a rapid growth. Like in that case, we can take the patient as clinically diagnosed NTM also, because we cannot take, like if you take 2 culture, you should be 30 days apart also. It will take 2 to 3 months and the disease getting worse. In that case, we can have the registry from the DTC, and then we can say what type of organisms like NTM, what type of that NTM is common in our scenario, and accordingly we can start regimen also. And meanwhile, after 2 months, and we'll see the clinical response of the patient also. And meanwhile, within 2 months, that reports will be there with us, and we can start our regimen, like change the regimen also.
I'm going to go to Dr. Khushboo. Dr. Khushboo, is there anything on the CT which helps us, tell us, think of NTM, think of fungal infection?
So for fungal, obviously the high attenuation, the peripheral halo, if we start seeing a lot of G surrounding the bronchiectasis, which means that there is some kind of invasion. But predominantly when we are talking of bronchiectasis and fungal, ABPA is the commonest, in which case high attenuation mucus is the commonest sign. And for NTM, more often the way we see, although it's not a very definite sign, but when the disease is more profuse, more symmetrical, NTM is more on cards than a tubercular infection.
Absolutely.
So,
yeah, fairly extensive, especially when you see a lot of nodules involving both lungs fairly symmetrically, that gives you this gut feeling that you may be dealing with NTM infections.
True.
Sorry, were people able to hear me?
Yeah, we can.
I think lost you in between.
Okay, sorry. So, Dr. Tarang, I'm going to go back to you on that. We've discussed this before, post-TB bronchiectasis and other bronchiectasis. How do you tell the difference? I think, Dr. Tarang, you're muted.
Yeah.
So post-TB bronchiectasis, one of the most common causes in the Asian EMBARC registries, which was seen across the Indian and the KIMBARC registry as well. Upper lobe predominance and associated radiological factors like pleural thickening or parenchymal calcification generally would suggest that there is a post-TB bronchiectasis sort of etiology. Across all the trials, the post-TB bronchiectasis was associated with more severe radiological extent. They had a worsened lung function, and almost 2/3 of these patients in EMBARC India and the KIMBARC registry were associated with airflow limitation. So which actually makes one ponder that did they have this TOPD sort of a coexistent phenotype along with that? So these patients are much more likely to be treated with inhalers, with inhaled corticosteroids, and one of the things that also need to be remembered is that these patients have a lot more hemoptysis and a lot more symptom burden. The facet score also is higher in this particular cases, and they might not have the conventional cough with expectoration that other patients may have. Previously, what was known as the bronchiectasis sicca. In the KIMBARC registry, a lot more NTM was isolated in this particular group of patients, but the similar wasn't seen in the EMBARC India registry. So definitely post-TB bronchiectasis, you would expect them to have a more radiological extent, more severe impairment in their lung function, and a coexistence of a tuberculosis associated pulmonary disease. So I feel it is a different phenotype that needs to be looked at.
Absolutely. I'm going to ask just one question to each of the panelists, and there are a lot of questions from the audience who I think deserve to have their questions answered by the panel. Cystic fibrosis in adults, we don't often think of it, but how often do you see this problem in adults? When do you suspect it? How do you confirm it, Dr. Parvaiz?
So I think in my lifetime, I have seen lots of myths being busted with the advancement of medical science. I remember treating patients of gastrointestinal bleed as an intern by giving them ice-cold milk through a rice tube, to the current times when it is being treated with advanced endoscopic procedures and giving them intravenous PPIs. So I remember the same thing about cystic fibrosis. This was a disease which was believed to be of the Caucasians alone, and it would be very rare for any physician in India to consider a diagnosis of cystic fibrosis, even in children, let alone in the adults. But over time, it has come to be recognized as a distinct entity causing a pulmonary and extrapulmonary disease in India, and there are registries and there are elegant investigators who have reported specifically from northern India, and Dr. S.K. Kabra from All India Institute of Medical Sciences, a huge series in children. But I was one of the first people to actually report about cystic fibrosis in 3 adults who had extensive bronchiectasis, and we did the mutational profile, the sweat chloride, and we found that it fit the criteria, and we reported them. And in response to that, there was actually an editorial question asked by one person from the US who said that, how did it reach Kashmir? So the point is that a disease which was thought of to be non-existent in the country, children as well as adults, is not only seen in children, but is seen in adults as well. So who do we think of having a cystic fibrosis in adults? Anybody who has a frequent infection, frequent pneumonias, other lung infections, somebody with persistent cough, frequent wheezing, and somebody who has non-pulmonary manifestations, like somebody has a small bowel diarrhea, chronic diarrhea, foul-smelling stools, or greasy stools, suggestive of an exocrine pancreatic deficiency. Somebody who tells you that my skin tastes like salt, or poor growth in a person who is having a good appetite and seems to be taking good food. So these are conditions which can prompt you to a diagnosis of cystic fibrosis. And I must say, emphasize that cystic fibrosis does occur in India and does occur in adults as well.
Absolutely, absolutely. Thank you. That was a very detailed answer. The last questions to each panelist before we go on to the audience. Dr. Savita, how do you use antibiotics in bronchiectasis? You know, you can use it cyclically or you can wait for an infection. Which do you choose and what are the advantages of each approach? Dr. Savita, you're muted.
Yeah. So whenever there is an obvious infection, I usually treat the patient with that, not with the cyclical, because if we'll give cyclic antibiotics, they have so many, patient may have side effects also, like patient may have other symptoms also, and the patient may develop drug resistance also. So usually I give whenever there is an infection and there is some like pathogen is grown on that culture according to the culture and sensitivity. I start, and because culture takes time, like it takes 2 to 3 days to come, and we have to start. Then empirical antibiotic we can start according to the symptom as well as the which is a commonly grown pathogen in that area or from the previous history of his or her culture also. So usually, is whenever there is any definite pathogen grown, then only we have to give, not the cyclical.
And you use nebulized antibiotics as part of your regimen?
Yeah, sir. Actually, mostly whenever there is a heavy growth of pseudomonas, only then I start with the nebulized tobramycin or colistin. But as such, with the oral or IV antibiotic accordingly.
And, you know, we spoke about prolonged courses of antibiotics, which is recommended. When we say prolonged, how prolonged do you want it to be?
Sir, depending upon the symptom also. Like, see, one is the course of treatment according to the infection, and one is prophylactic antibiotic. So, course of treatment during the infection, depending upon what type of growth is, like it is heavy, moderate, or scanty growth, according to the colonization. Like if it is heavy, then we can give to the 14 days to 21 days also. And if it is scanty and the symptoms are less, then oral antibiotic with 7 to 10 days are also enough. And if we'll see the prophylactic antibiotics we are giving, like macrolides, or we are giving to the patients, then accordingly, when first we have to thought that whether to give that prophylaxis to the patient or not. But if we're choosing to give prophylaxis, then if we're giving macrolides, like then we a minimum 6 months I used to give, but that is low dose and thrice weekly.
Yeah, so Dr. Ajay Lanjewar asks, what is the protocol for a macrolide? Azithromycin 250 mg for 3 months or 12 months? Do you want to give it lifelong or intermittently?
So actually, for the duration of a macrolide, we'll see there is no such guidance that for how long we should give antibiotics. So I usually give for 6 months. That is low dosage, 250. But as sir has also talked in his talk also, Sir Rajadhar sir, like if the patient is having pseudomonas, then we are giving inhaled, and if the patient is having non-pseudomonas, non-cystic fibrosis type, then we can give macrolides, that is azithromycin usually. And ERS 2017 guidelines also say that the patient is having frequent exacerbation, which is non-pseudomonas, and more than 3 exacerbations in the past year, then we can give macrolides, mostly azithromycin. And 2-3 trials has also been done by the use of antibiotics also, like BLESS trial, BAT trial, and a BRACE trial. And for minimally 6 months, I usually give, but not. But before starting that prophylactic macrolides, we should rule out NTM first. And then we should also, because if the patient is having NTM or having risk of developing that, then we'll end up with a very good drug, which should be there in the course of treatment. And we should also think it may cause some GI symptoms mostly. And we have to rule out whether the patient is having cardiac disease or not. If there is any cardiac event, we cannot give macrolides also and azithromycin. So while seeing these factors, we can start with azithromycin in the patient, those who are having non-pseudomonas colonizer, having more frequent exacerbations.
And among other things, please consider doing a pure tone audiometry, because azithromycin is known to cause significant hearing loss.
Absolutely.
So, you know, extending that, the same question about nebulized antibiotics. Dr. Kranti, how do you use nebulized antibiotics? Anything particular? and especially what is the role of Pseudomonas infection in these patients?
Pseudomonas is very notorious actually for bronchiectasis because it could be one of the causes. Because if Pseudomonas causes primary necrotizing bacterial pneumonias, so it could be one of the cause of bronchiectasis, and it could be a colonizer. So once it is a colonizer of the bronchiectatic airways, obviously it is going to cause extensive lung damage. It is going to impair our lung function, and it will be one of the important causes of frequent exacerbations. So when we are talking about the use of nebulized antibiotics, so there are very clear-cut guidelines about it as per the ERS. So according to that, when we talk about the eradication therapies, so if we have a new isolate of Pseudomonas aeruginosa, then it is one of the indication for antibiotics. So talking about the nebulized antibiotics, one indication Dr. Raja has already said is that if the patient is having 3 or more exacerbations per year, so that patient needs treatment. So nebulized antibiotics could be one of the choice. And when we talk about Pseudomonas, so in Pseudomonas, yes, we can give nebulized antibiotics. But when we talk about non-Pseudomonas infections, where our drug of choice may not be these drugs. However, if the patient is intolerant to the standard therapies or to a particular organism, though susceptible to some antibiotic, but because of ADRs or because of intolerance, we are not able to give that. So in such patients also, we can consider giving the nebulized antibiotics. Then yes, in certain patients with severe lung disease, with frequent exacerbations, with comorbidities, so these are the patients where nebulized antibiotics can be having any role. So when we talk about the various nebulized antibiotics which are available with us, Savita ma'am has already told, but yes, we have colistin, we have gentamicin. And in gentamicin, we give it 80 mg BD nebulized form. So when we talk about colistin, it is 1 million international units BD, again for a period of 6 months. And when we, another thing ma'am has already told is tobramycin. So tobramycin in nebulized form, we give 300 mg BD for a period of 6 to 12 months. So tobramycin and gentamicin we usually give for 12 months and colistin, yes, for 6 months. So by giving these nebulized antibiotics, we may be having various benefits, like obviously the number of exacerbations will be decreasing. Their time to first exacerbation will decrease. And yes, sputum purulence and breathlessness is also found to decrease with the use of these nebulized antibiotics.
And with less systemic effects.
Less systemic side effects.
Dr. Parvaiz, I'm going to go to you on this. Who else can I go to? Are vaccinations important in patients with bronchiectasis? Which ones do you prescribe?
Yes, Dr. Murli. I mean, I think if you talk of a hard core evidence for use of influenza or other vaccinations in bronchiectasis, the world data are wanting on that. But nonetheless, given the fact that vaccinations have a use in most of the chronic respiratory diseases, it has been recommended that we offer annual influenza vaccinations to patients with bronchiectasis. Also offer them pneumococcal vaccination. And the one vaccine that has been recommended is the polysaccharide vaccine. That is, though the evidence is a weak evidence. However, now with the greater evidence of use of the conjugate vaccine giving a better protection, there is a trend towards using the pneumococcal conjugate vaccine with an overlap of the polysaccharide vaccine, much the same way that you would use it in other chronic respiratory disorders like the COPD and like. There is a growing, noise about using of Haemophilus influenza, these vaccines also. However, there is no definite evidence to that because the Haemophilus influenza that we grow in patients with bronchiectasis are generally the non-typable one. And the vaccine that is available is against Haemophilus influenza B. And the other typable ones are even not covered, the A to C. So mostly the vaccination that is recommended as of now, it would be for influenza and pneumococcal. And there seems to be a noise about the usage of influenza, Haemophilus influenza B also, but we don't have direct vaccines against the non-typable vaccine, Haemophilus.
Right. For lack of time, I'm going to go probably the last question and then invite one closing comment from each of you. We've not covered many areas. We've not covered the PEP devices, mucolytics, and so on. But really, there are so many questions. I'm going to come to the last few questions. Dr. Tarang, Dr. Hamid asks, should we have a low threshold for surgical intervention in localized bronchiectasis? But he says, I've come across patients who were operated on for this localized or focal bronchiectasis, but on follow-up bronchiectasis appeared in other areas too. So is surgery useful? Where is it useful? And how do you predict who's going to have a recurrence and who's not?
So in a very crisp way, I would say it is important to first understand what is the etiology of the bronchiectasis. If you have a cause like cystic fibrosis, for example, which has got untreated, surgery could actually be useless, because as the doctor in the question box says that probably you could have a bronchiectasis on the other side. So there are very clear 4 indications of surgery in bronchiectasis. One is localized disease. So this would be relevant for post-TB bronchiectasis, for example, where you know that the inciting agent or the inserting agent has now been effectively eliminated. Or these could be patients with a bronchial stenosis or an endobronchial lesion leading to bronchiectasis. If there's a severe localized disease, so for example, patients with post-TB destroyed lung, in this particular group of patients also surgery could be useful. Massive hemoptysis. So for patients who have actually undergone a bronchial artery embolization and despite that are having a recurrent hemoptysis, you could actually think about surgery. And in certain infections like a persistent NTM infection, or in patients with multi-drug resistant Pseudomonas or MRACS in this particular patients, you could actually offer them surgery where there is persistent and recurrent infections in this particular case. Transplantation is right now gaining a lot of coverage when it comes to bronchiectasis. So, but again, these are the group of patients who generally have been offered a retransplant after a few years, especially if they have been subjected to a lung transplant while they were young because of cystic fibrosis. But one thing I think in a nutshell has to be remembered, as Dr. Parvaiz sir said about the comorbidities, all of these things have to be addressed before you refer the patient for surgery. A optimization of these patients is extremely important, with nutritional counseling, with rehabilitation, and only after that you would consider sending the patient or referring the patient for surgery.
And typically you don't have a choice but to do bilateral transplants. You know, it's very difficult to do a unilateral transplant. He's got a sump of infection in the other lung. So that's something again to keep in mind. Last few points. So I'm going to ask each of you on one of the mucus clearance techniques, starting with Dr. Savita, mucolytics. Do you use mucolytics? How would you use mucolytics?
Yeah, so patients, those who are having difficulty in expectoration and more amount of expectoration, and more probably having most difficult to expectorate. In that cases, we can use mucolytics. But whenever patient comes to us and when we discharge the patient or we tell them and we advise them to have mainly hydration, like if the patient is having more hydration, because water is the best mucolytic, so we tell them to have proper hydration. Probably patient does not having a case of core pulmonary, so in that case we have to restrict the fluid. And that if the patient is not getting better with the proper hydration, then sometimes even the patient we can prescribe N-acetylcysteine or Ambroxol or 3% or 7% hypertonic saline. Mostly I used to prescribe the oral N-acetylcysteine because that is easy to take at home. And even then, if the patient is having, then we can go for inhaled N-acetylcysteine also.
And one of the things to remember, of course, is that sometimes these nebulized medications, including hypertonic saline, can produce severe bronchospasms.
Spasm also,
Yes.
yeah.
So, Dr. Kranti, postural drainage. All your patients get postural drainage? And
yes, postural drainage is very, very important. I think this is the age-old technique which has been used since years and years together. And airway clearance techniques along with postural drainage, every patient should be taught before the patient is, once the patient is admitted and discharged from us, the patient should be told to use the postural drainage techniques. And yes, rehabilitation and exercise, another important thing. So the literature has shown that the pulmonary rehabilitation and exercise that has really improved the outcomes in patients with bronchiectasis. So yes, we have to go for these things.
And Dr. Parvaiz, active cycle of breathing techniques. How closely do you work with your physiotherapy, respiratory therapy team in all these, postural
I
drainage,
think,
CBT.
yeah, active cycle breathing. I mean, that is a standard mode of pulmonary rehab in patients who have a thick viscid mucus. And we have those 3 phases, and then they huff it out and try to mobilize the secretions by inspiration, deep breathing, and then huffing and probably coughing out also. Yes, I mean, once we have a patient who requires some kind of pulmonary rehab, we have a dedicated the physiotherapist who takes care of the pulmonary rehab. And one of the ways that she does help the patients with would be active cycle breathing. And they also use some other PEP devices or even oscillation devices to help the patients bring out the sputum, specifically if it is not getting out. And there is a cohesion with other modalities like some it was talked about the mucoactive agents, be it acetylcysteine or carbocisteine, or normal saline nebulization or even hypertonic saline nebulization. And sometimes people have used even mannitol.
Can you tell us a little more about these PEP devices, Dr. Tarang?
Yes. So I think one of the biggest messages that has to go across is how important airway clearance measures are in bronchiectasis. That is a single most important intervention that would improve the quality of life and reduce exacerbations. So oscillating PEEP devices generally there are 2 major oscillating PEEP devices that are available. One is the flutter wall devices, or largely known as the Aerobica, and the Acapella. It is very easy to use. The patients use it at home, assisted by the physiotherapist, and it is a matter of routine that they have to take out this sputum every day, and you would start seeing improvement from week 1. I mean, I'm not even underestimating it. You would see improvement from week 1. Along with that, there is also physiotherapy wise, you have to address the exercise intolerance of the patient through strength and aerobic exercises, and of course respiratory muscle training through IMTs, or inspiratory muscle training exercises. I think all of these things have to be taken together when you actually prescribe a patient a mode of physiotherapy. And this is something that has to be done for each and every patient of bronchiectasis. As I say, the single most important intervention when it comes to bronchiectasis.
Yeah. So, and the guidelines suggest that you should do it in steps. So you do the ACBT first or postural drainage. Not very effective. Then you go on to use one of the PEP devices. And then if you're still not very effective, then you use nebulized saline, including hypertonic saline. So bronchodilator, mucoactive treatment, then you do the airway clearance. Still not getting better, consider whether you should use a nebulized antibiotic or an inhaled steroid. And one of the last questions I'm going to leave with y'all with this is, Raja mentioned this. In the EMBARK study, we found that there's an overuse of inhaled steroids, overuse of ICS-LABA. When would you prescribe these in bronchiectasis, Dr. Kranti, and when would you not prescribe it in bronchiectasis?
Yes. So Dr. Raja has already told that ICS, if eosinophil count is more than 300, we can think about prescribing ICS. And if it is less than 100, then we should not think about it, because ICS is obviously associated with increased chances of oral candidiasis and other side effects like dysphonias. Yes, if the patient is having comorbid condition like asthma and COPD, we should not refrain from starting ICS. Talking about the LABAs, again, the patients of COPD and asthma, they will be requiring LABAs. And as we have already discussed, there could be some patients who may be requiring nebulized antibiotics or say nebulized hypertonic saline. So these are the things which can be precipitating bronchospasm in these patients. So before we give these drugs, yes, we can think about giving these patients with LABAs, inhaled like long-acting beta-2 LABAs. And yes, if you have to use it, decreasing the dose of rescue medication, that is beta-2 agonists, we have to avoid. So we may be using LABAs in these patients. But yes, COPD asthma is definitely an indication for using ICS-LABA in our patients.
And please do not use it unless you have these specific conditions.
Yes.
You're running the risk of worsening infections.
Would we use glycopyrronium in this group of patients with COPD and bronchiectasis?
Would you use glycopyrronium in patients with COPD?
In patients with COPD?
In these patients with bronchiectasis.
That's what, comorbid COPD and bronchiectasis, or all bronchiectasis? Which is your question?
So no, with COPD and bronchiectasis, wherever.
COPD and bronchiectasis.
So I
So
think,
in COPD, yes, the
if I
standard
may,
treatment for COPD that will be given. If the patient is group E, then yes, the patient will be requiring a LABA/LAMA and ICS triple therapy.
Dr.
No,
Parvaiz,
but
you wanted to say something?
so something, I mean, in the answer to that question is that the simple answer is that if you are wanting to give a drug for COPD,
Yes,
then the COPD guidelines come into effect.
yes.
You're not treating bronchiectasis with a glycopyrenium or tiotropium. You're basically treating COPD part of it. And so you treat it in the way that you would want to treat COPD. This is a COPD, just has an accompanying bronchiectasis as well.
So you go by what is the main problem. Treat the
Yes,
main problem.
absolutely.
Closing remarks from each one of you. Is Dr. Khushboo is still here? I'd like her to give one closing sentence. Think she's left. So, Dr. Savita,
Yeah.
one
See,
sentence to sum up.
I just wanted to say when we are suspecting patient, then we should first see whether there is any underlying etiology also and treat the patient symptomatically also, so that his or her quality of life also becomes very good, because the patients are having very good amount of sputum and their quality is very bad. So to improve the quality of life, we should treat the patient also accordingly.
Dr. Kranti?
Since my own area of interest is psychological afflictions and respiratory diseases, and we were supposed to talk about anxiety and depression. So I'll just add up that yes, these patients have anxiety to the extent of up to 50% in the studies, and depression to the tune of like mild and moderate depression to the tune of 25%, and severe to the tune of 10%. So when we are talking about quality of life, when we are talking about our patients to be treated in totality, so yes, we should use our various screening tools for associated psychiatric comorbidities as well. And we should screen them and we should try to treat them, because ultimately the quality of life is going to improve if we catch the disease, we treat it as a whole.
Dr. Tarang?
So I think these are exciting times for bronchiectasis. A lot more data incoming. There is talk about phenotyping and endotyping with with new biological agents that are supposed to be used. The microbiome still seems to be like a very exciting part. And these new anti-inflammatories in bronchiectasis, this is such an exciting time to study bronchiectasis.
Absolutely, absolutely. It is an exciting time. We've seen, as Dr. Parvaiz said, such a sea change in our time. And I'm sure even the younger ones among you are seeing changes from when you all started to now. So exciting times. I'm going to come to Dr. Khushboo last. I'm going to ask Dr. Parvaiz now. One sentence, Dr. Parvaiz.
I think I go with everybody's opinion, and I think for the young people who are listening to us, suspect bronchiectasis, diagnose it, try to arrive at the etiology and institute treatment as directed against the pathogen, and try to do it according to the guidelines. Don't go by whims.
And the guidelines are changing all the time, so please keep updated.
Yes,
Dr. Khushboo,
absolutely.
we started with you. I'm going to leave the last words with you. I think you're muted, Dr. Khushboo.
I was logged out repetitively.
Sorry?
Sir, I missed the last couple of minutes of what the discussion was because my connection was getting logged out repetitively.
Okay. No, so my only thing was, can you leave us with one sentence as a radiologist? What would you advise the audience and when they're managing patients with bronchiectasis?
So whenever you get your HRCT done, please ensure a proper protocol and thin HRCT cuts are done. Try to get your images in soft copies. That's the one thing.
Great. So I'm going to stop at this point. Thank you all for a very patient hearing. Our audience and an absolutely wonderful panel who I think have given us a lot of information. A few key points: identify the etiology of bronchiectasis, target the treatment, which is mainly improve mucociliary clearance, treat and prevent infections, reduce inflammation. And that is becoming the focus now, especially as Dr. Raja was telling us, the use of biologicals and other agents as anti-neutrophil elastase agents. Bronchiectasis is heterogeneous. So identify the phenotype, the endotype, which is becoming clearer, and therefore we'll be able to offer personalized treatment. Use a combination of clinical tests, including very importantly, the history, the symptoms, couple it with the radiology, send sputum cultures, use the blood tests, use the more appropriate tests which give you a diagnosis to the rarer causes of bronchiectasis, but keep them in the top of your mind. Every patient is different and we need to look for these. I'll stop at this point. Thank you all for a very patient hearing. Thank the Indian Chest Society, Dr. Amita Nene, Dr. Raja Dhar, Dr. Sandeep Salvi, Lupin for support, and of course the tech team. Ms. Aditi Vaidya has been with us throughout, Raja Ganguly has been with us throughout, and as always, Dr. Khushboo, we're most grateful for your constant support of the pulmonology teams. Hand back to Mr. Raja Ganguly.
Thank you so much, sir. I mean, it's an amazing program. And thanks especially to you, Dr. Khushboo, Dr. Kranti, Dr. Tarang Kulkarni, Dr. Raja Dhar, Dr. Parvaiz Koul. I mean, it's been an amazing program. Thanks from the core of our heart to all of you. Rightly said, you are the Einstein of the respiratory medicine, sir.
Thank you.
Thank you.
Amazing. It's an amazing session. Thanks a lot, sir. I joined late because I was traveling. I came to just landed in Chennai from Delhi. So, but it was amazing, sir. Thank you so much.
Thanks a
Thank
lot.
you.
Good night, everybody. Looking forward
Thank
to
you.
next
Good night.
Thank you.
Good night.
Goodbye.
Dr. Jindal, thank you so much.
Yeah, welcome, sir. Welcome. Yeah, thank
Thank
you to
you.
you also to
Yeah.
become.
Yeah, it's amazing.
Yeah, thank you.
Yeah.